Now it's a great pleasure for me to introduce my co-moderator for the next presentation, Dr. Amit Maydeo. He's head of the Baldoda Institute of Digestive Sciences in Mumbai, and all of us know him as a very skillful endoscopist, as a great researcher, and he's head of a huge department, has a lot of expertise in many areas in endoscopy. Now, Amit, it's a pleasure now to listen to you, and today you're talking about endoscopic treatment of chronic calcifying pancreatitis.
Thank you so much, host. So we can start my lecture. I would like to first of all thank Professor Inouye for giving me this opportunity to talk to you today in Tokyo Live Global Endoscopy Network on endoscopic treatment of chronic calcificating pancreatitis. In connection with this presentation, I have no conflicts of interests or any disclosures to be made. Chronic pancreatitis is a very varied disease having a varied etiology, a varied incidence, and a varied pathomorphology, as you can see from these images. And this pathomorphology can vary from western to the eastern part of the world, and from its etiology, from alcoholic etiology to idiopathic or tropical pancreatitis. The main manifestations of chronic pancreatitis can be either a stone predominant disease, a stricture predominant disease, or it can be a combination of stones and strictures. There can be associated inflammatory masses, pseudocysts, or even biliary strictures. And this entire pathomorphology can vary between its etiology, like tropical, to alcoholic, and is manifest in various parts of the world in various pathomorphologies. The established indication of treatment in patients of chronic pancreatitis is basically pain relief. However, lately realized that the possible indications for treatment could be also an improvement of endocrine as well as exocrine function and possibly delay progression of the disease. If you were to see the pathogenesis of pancreatic stone formation, whatever be the etiology, whether it is tropical or alcoholic, the basic issue is that there is an increased pancreatic stone protein, which is almost more than 400 times that of a normal person, in the pancreatic juice of these patients, which causes a sluggishness of the juice flow. It can cause blockage of the duct with protein plugs, and then when calcium gets deposited on the protein plugs, it can lead to either soft or hard stone formation. Studying the etiology of pancreatic strictures, you can see here the commonest reason is the sentinel acute pancreatitis episode, which also is called as the Kloppel's hypothesis or the SAPE hypothesis, which is a necrosis fibrosis sequence. And with the patient having one sentinel episode, it leads to inflammation, injury to the duct, stricture formation, sluggishness of the flow, further episodes of acute pancreatitis, and the patient enters into a vicious cycle leading to hardening of the gland and then stricture formation, either single or multiple in nature. The main credit of endotherapy of chronic pancreatitis goes to these pioneers all over the world. For example, Nick Sohendra from Germany, Michel Kramer from Belgium, Kees Hubretske from Netherlands, Joe Geenan and Richard Kozarek from United States of America. And if you see the initial publications from these pioneers in the 1980s, just early 1990s, the sort of conclusions which they reached in these publications were that pancreatic duct stenting is possible and it can be done with acceptable adverse events of around 20 to 40%. Endotherapy was only advocated for temporary use. It could become a good bridge to surgery, and it does not lead to acute pancreatitis. Since then, over the last 30 to 40 years, a lot of evolution has occurred and clarity of thoughts as far as endotherapy of chronic pancreatitis. And today, we have reached certain protocols of treatment. The most important pre-procedure workup for patients of chronic calcifying pancreatitis before you embark on endotherapy is to perform a good fluoroscopy or a plain X-ray. And if there are patients having stones, you should see the number, size, location, and density of any radiopaque stones. In addition, a properly performed MRCP and if required an endoscopic ultrasonography or a CT scan should be done to study the ductal anatomy for the presence of associated strictures, pseudocysts, complex ductal disease, or even space-occupying lesions. If you have a patient of pancreatic ductal stones, and if you see here, in pancreatic stones, 90% of the stones are usually radiopaque, and the special features of these stones are that they are usually hard, they are spiculated, they are usually impacted, and they are associated with strictures or complex pathology, and sometimes can be inaccessible. In only a small 10% of patients, you have small radiopaque stones, or you may have radiolucent stones. In patients who have got radiolucent stones, the treatment is quite simple by performing an ERCP. And even if you have a patient like this with large radiolucent stones, we can perform an ERCP, opacify the duct, and then after doing this, we can do a wide pancreatic sphincterotomy and go ahead and then perform a pancreatic sphincteroplasty by using a large balloon of up to 12 mm. Here you can see now how we perform the pancreatic sphincterotomy somewhere at 12 to 2 o'clock direction. And as we cut the pancreatic sphincter, you can see that there is a flow of the pancreatic juice along with some of the radiolucent stones. And then either over the guide wire or by the side of the guide wire, we can place in a large balloon and dilate the pancreatic sphincter up to almost 12 mm. And then after performing the pancreatic sphincteroplasty, we can go inside and then place a stone extraction balloon extracting catheter, and we can take out chunks and chunks of these radiolucent stones, which are actually conglomerated pancreatic stone protein, and sometimes we can achieve complete pancreatic ductal clearance in a single sitting of ERCP. If the patient has radioopaque stones, then it is necessary that we have to pulverize these stones beforehand by using Shockwave lithotripsy. Today, with the use of third or fourth generation Shockwave lithotripters, we can achieve an accurate, efficacious, and a very safe pulverization of these stones. And if you see here, the end point of Shockwave lithotripsy, which should be done before ERCP in patients having radiopaque stones, is basically complete pulverization of the stones to fragments which are less than 3 millimeters in size, and we make them out by seeing a loss of density of the stones on an X-ray or a fluoroscopy, spreading of the stones or the fragments along the duct, and in some cases even a complete disappearance of the stones after a properly performed ESWL. After we have done a ESWL, then we can go ahead and perform an ERCP and do an extraction of the stones by again performing a pancreatic ductal sphincterotomy, and then we can extract these pulverized stones by using a simple balloon extractor. Here you can see now that after cannulating the pancreatic duct, we opacify the duct, and then we pass in a sphincterotome, perform a pancreatic sphincterotomy, and then by use of a stone extraction balloon, we can take out these pulverized stone fragments and then achieve a ductal clearance. If all the stones are not cleared in the initial setting of ERCP, then a temporary 5 or a 7 French stent is placed. The patient is called back after a few months, usually after 3 months, reassessed. If there are some more radiopaque stones, further ESWL is done and the therapy is progressed until we can achieve a. If you were to see this latest publication, which was published in 2020 on the success of extracorporeal shockwave lithotripsy and ERCP in symptomatic pancreatic duct stone disease, you can see from these results of the pooled data, complete ductal clearance after ESWL and ERCP can be achieved in almost 70% of the times. Complete absence of pain during the follow-up was in almost 65%. And you see here, complete stone fragmentation could also be effectively achieved. So today, therefore, for pancreatic stone disease, in those patients who have radiopaque stones, ESWL is the cornerstone of therapy before you perform ERCP. Whereas for radiolucent stones, which are not seen on a fluoroscopy or an X-ray, we can directly proceed with an ERCP, perform a pancreatic sphincterotomy, a sphincteroplasty, and remove the stones. Stricture predominant disease patients can be treated in a slightly different way because you have different types of strictures in chronic pancreatitis. They can be single, multiple, tight, soft, or complex strictures. Pleasantly accepted protocol for stenting in stricture predominant disease and chronic pancreatitis are the amended new guidelines from the ESG that were published in 2019. It is advocated in stricture predominant disease that we try to place either a 5, 7, or a 10 French stent, whichever is possible, across the stricture. And then we keep on placing these stents until we reach at least a 10 French diameter as soon as possible. Once we can place a 10 French stent, we keep the stent inside for at least 1 year, remove the stent after 1 year, and then reassessment of the stricture is done. If the stricture persists after 1 year of 10 French stenting, then the patient should be given a choice whether they want to go in for a multiple stenting regime or do a surgical consultation. In patients who have pseudocysts associated with chronic pancreatitis, the good part is that almost 40 to 60% of such pseudocysts in chronic pancreatitis usually communicate with the main pancreatic duct. Therefore, transpapillary stenting is the first line of treatment, as you see here, for all patients who have pseudocysts associated with chronic pancreatitis, which are in communication with the pancreatic duct. Today, therefore, what is the accepted protocol for endotherapy of chronic pancreatitis? You see here that fluoroscopy and MRCP are extremely essential before planning your therapy. One may require to do an endoscopic sonography or a CT scan if there are inflammatory masses or a suspected pancreatic cancer. In patients who have got radiopaque pancreatic stones, shockwave lithotripsy has now become mandatory as the cornerstone of therapy, only after which you can perform the ERCP after achieving a proper pulverization of the stones to less than 3 millimeter fragments. In the radiolucent stones, we can directly perform the ERCP, perform a pancreatic sphincterotomy, a sphincteroplasty, and clear the duct. If you have a stricture predominant disease, then you should follow a judicious stenting protocol rather than an arbitrary protocol, and only after achieving a complete stricture opening or a stricture resolution, then the patient can be given a stent-free trial. It's very important before embarking on endotherapy that we have a defined endpoints of stone clearance as well as stricture resolution. In general, if you were to decide which patient is more suitable for a surgical treatment or an endotherapy, usually those patients who have a tropical etiology, a simple pathomorphology, a stone disease or a simple stricture disease or dilated ducts are suitable for endotherapy. Whereas those patients who have a predominantly alcohol etiology, a complex pathomorphology, a small duct disease, or a stricture predominant disease, they usually do not fare well with endoscopic treatment and are better off with surgery. Thank you for your attention.
Thank you, Amit, for this excellent presentation showing the variety of techniques and also the evidence that we currently have. Just a question on lithotripsy. Is the direct approach with pancreatoscopy and pancreatoscopic guided lithotripsy an alternative to ESVL?
Yes, it appears to be an alternative, attractive alternative, but to tell you the truth, in reality, it may not be always possible to reach the stone by using a pancreaticoscope, even if we use a spyglass, because of the curved pathway, and especially if the stone is located beyond the genu. Even if you can reach the stone, sometimes it's difficult to bring your EHL probe or your laser probe end on the stone. It tends to go tangential, and then we can't break it. Another issue is if there is an associated stricture. If there's a stricture, we cannot pass the scope right till the stone. So therefore, presently at least, there are some limitations of using a pancreaticoscopy guided laser or EHL for breaking these stones. But definitely it's a good alternative if the stone is located in the head and if the stone can be accessed. In fact, this is one of the areas of studies where we can do a prospective study to compare ESWL with pancreaticoscopy, because in some countries ESWL is not available.
You showed the scientific data of many uncontrolled studies on the endoscopic approach to chronic pancreatitis with fantastic results in some of them. However, as we well know, in randomized controlled trials of endoscopy against surgery, the results were worse. And it's now difficult in interdisciplinary meetings to argue for endoscopy as a first approach, because surgery seems to be more effective, in particular in the long term. What is your position on that?
I agree with you. I agree with you that there were at least 3 randomized controlled trials, and the latest trial also showed that surgery is superior to endoscopic treatment. However, all said and done, those of us who have been treating these patients of endotherapy, it entirely depends upon the etiology and the pathomorphology. Because if you were to see these trials, most of these patients who presented in these trials have been having a complex morphology. They have had alcohol as an etiology. Whereas in a place like India, where we see 80% of our patients having idiopathic or tropical pancreatitis, stone predominant disease with dilated ducts, here we are finding the results of endotherapy to be far superior than the published literature. So therefore, the problem is, even though these trials are good, they have been published in reputed journals, I think it entirely depends upon the type of morphology you see in the place where you work, and how complex is the pathomorphology, and how easy and is your endotherapy going to be. I would like to take the opinion of the other stalwarts who are there with us on this panel.
May I ask a question, Mr. Chairman?
Yes.
Just one question that I ask myself quite often is, why should we continue to speak about endoscopic treatment of chronic pancreatitis? In my experience nowadays with chronic calcifying pancreatitis, without any endoscopy, with only shockwave lithotripsy, almost 40 or to 50% of patients can be managed adequately. So we always mention about lithotripsy before endoscopy, but my question to you, Amit, is which is the place of lithotripsy without endoscopy? Because this is much less, I'm speaking about extracorporeal shockwave lithotripsy, is much less aggressive than lithotripsy with endoscopy. And this has been also shown in a randomized trial that it can achieve initial results which are similar, especially in those patients who have obstructive stones.
I completely agree with you, Jack. In fact, in quite a few of our patients also, we subject them to ESWL as a monotherapy. However, if we see a high stone load, for example, the stones are not only located in the head, there are some stones in the body of the pancreas. And so even if you break all the stones just conglomerate and they just form the plugs and they sort of block the duct. However, if you have less stone disease, less stone burden, predominantly in the head, I think it's a very good idea to go ahead and do a plain monotherapy as a ESWL. But I completely take your point, and we should try to attempt this in the future, that instead of subjecting these patients to ERCP after ESWL and just keep on repeating the ERCPs until we achieve a total ductal clearance. As far as the patient is stone free and as far as the pancreatic juice is flowing and as patient pain free, I think if we can achieve that with plain lithotripsy, I think that's a good idea.
Okay, thank you very much for your valuable comments. And now, Amit, it's to you to introduce the last speaker of the session.